My name is Silber. I'm from Munich, Germany, and for those who don't know me, I'm a cardiologist in private practice, but we're also doing invasive studies, interventions in a hospital. So I'm on both sides of the cardiology diagnosis and therapy. The topic is caring for the frail patients, and I'll talk about coronary artery disease. Since this is the first talk of this session, I was not sure if everybody knows what frail really means. At least I wasn't sure myself. So I looked up two dictionaries, and it says here, frail means weak or unhealthy, or I think what's important, easily damaged, broken or harmed. So a frail patient is some patient who can easily be harmed. And in the other dictionary, it's quite similar. It says easily led to evil and easily broken. So I think frail patients are those in which we should really think about what we are doing, not to harm the patient. And for those who still remember a little bit of Latin, nil nocere or primum non nocere is a Latin phrase that means first do not harm. So this is the major task for us in these frail patients. So I present to you a case, not an overview of frailty. And this is how in Germany we get the information from general practitioners if they are referred to a cardiology specialty practice. And what I translate to you, first you see the date of the birth. Well, this is a real patient, not a made up. This is not a setup. This is a real patient. Nothing has been changed. 88 years old, male patient, and he's referred because severe shortness of breath. Well, he told me he can only walk for about 20 up to 30 meters. He really has to stop. He doesn't get enough air, and the referring physician already increased the diuretics, so this might not be an only option. Well, first the history, the non-cardiac history. He has prostatic cancer for 10 years, but this is well controlled. CLL, chronic lymphocytic leukemia, for 2 years, also more or less well controlled, so this is not the major problem. Known renal insufficiency and also an infrarenal abdominal aortic aneurysm. No pulmonary disease has been diagnosed, so pulmonary disease is not the reason for his shortness of breath. What about the cardiac history? Known three-vessel disease. In 1989, he suffered an inferolateral myocardial infarct. He got stents in the LAD in 2014, and in the same year, an attempt was made to reopen a chronic total occlusion of a large marginal branch, which was not successful. He has known mitral insufficiency and a lot of cardiovascular risk factors, as you can see here. Of course, his major risk factor is age. He's 88 years old. These are the lab values referred from his practitioner. Hemoglobin is more or less not the reason. He doesn't have severe anemia as an explanation for the shortness of breath. His LDL, interestingly, is very well controlled with 62, and of course the known renal insufficiency with a current GFR of 28. This is his EKG. I think we do not have to discuss a lot about this. More or less okay EKG, no left bundle branch block. I'll show you some echo images. Well, I'm not the big echocardiographer, I'm more invasive, but the left atrium size in square millimeters is slightly elevated, but not a huge left atrium. Of course, we don't do 3D LA volume determination in our practice, which is the best method today, but I think for this case presentation, this is quite good. Well, E2 for diastolic dysfunction is 11, so it's borderline. It's not severe diastolic dysfunction of the heart, which could explain his shortness of breath. And through the tricuspid regurgitation, a maximum pulmonary arterial pressure can be calculated as 41 millimeters of mercury, is slightly elevated, but not in a huge range. This is a video of the mitral regurgitation. And if you look, there are some beats with a major and some beats with a minor mitral regurgitation. He has some ventricular extra beats, PVCs. But if we look carefully here at the backflow to the left atrium, of course it goes to the roof of the left atrium, but the vena contracta is rather small, which is the better parameter. So more or less the real mitral insufficiency is not the real, probably, major cause, but it's very difficult because it's eccentric, and I was told from echocardiographic specialists that with eccentric jets it is very difficult to evaluate the real evaluation of the mitral insufficiency. What about its perfusion? We do myocardial scintigraphy with technetium tetraphosphine, and what you see is a large lateral scar. Stress rests the same. Since the patient has so much shortness of breath, short walking distance, we did pharmacological stress testing with Regadenoson, which in our practice replaced adenosine in total. So the lateral is more or less predominantly dead. So what's next? Who would do transesophageal echocardiography? If you say, I cannot really judge the mitral insufficiency, would you do, maybe the chairman would say, would you do the next step, transesophageal echo, or would you go for cardiac catheterization as next step to exclude progression, or would you go for non-invasive coronary angiography with cardiac CT? So maybe I'll ask the audience, who would go as next step for TE, transesophageal echo? Nobody. Who would go for cardiac cath? Some people, yes, one at least. Who would go for non-invasive coronary angiography? 1, 2, 3, yes. Well, actually the patient wanted non-invasive coronary angiography. Definitively no cardiac catheterization. He said, I want to have the non-invasive study. Well, first of all, in Germany, he's a social healthcare patient. Coronary CT is not paid by the social healthcare insurance, which are 90% of our patients in our country. But he said, well, I will also pay out of my own pocket, which of course I didn't want to. But with the age of 88 and stents, he probably pays a lot of money, and it's going to be an equivocal test result. So I tried to convince him to get a cardiac cath. He said, no, I had already cut down with a Sones catheter many years ago. And even worse, I had a radial catheterization, and he has numbness of the thumb and the index finger after radial access, and he said, never again radial access. So I said, okay, let's do femoral. No, but these are the pictures which he brought, and he said, I'm afraid that if you go through this aneurysm, bad things will happen, and don't harm me. But finally, I could convince him. He agreed to coronary angiography, and as you can see, the LAD stents are open, and the LAD is quite okay. But of course, this known occluded marginal branch, here you see it better from the circumflex artery, is there. And as you can see easily, the right coronary artery is dominant and is filled retrograde. Here you can see the occlusion of the right coronary with a little stump, so you might think that might be possible to reopen. Well, here's the left ventricle. I did ventriculography, despite he has severe renal insufficiency, but I wanted to have a real good ejection fraction, which is, as you can see here, in the medium range. If you look at the guidelines for heart failure, he really does not fulfill the criteria for medium reduced ejection fraction. Of course, the LVEF is in the range, but his left atrium is not really huge enlarged, and there was not a clear sign of diastolic dysfunction. So I would not classify him as HFMREF. But if you look at the inferior wall in the ventriculography, it moves quite well. So maybe reopening of the right coronary might still be a good choice. So what's our next step? I went to a surgeon, cardiac surgeon, presented the case, bypass 2 vessels and mitral reconstruction, and the surgeon said, no, better not. I will not touch the case. It's too risky, and probably the patient will have no benefit. Then I talked to a clipping specialist, Professor Köhl in Munich, and he said, I would not like to go straight to clipping. First, let's have some other tests, but this is not a real good clipping case. So what's left? Conservative treatment with optical medical therapy. These are all the drugs from the referring physician. As you can see here, the referring physician already increased torazamide, diuretics, but it didn't really help. And as you see on the bottom, yellow highlighted, he already tried to switch to Entresto, but he had to withdraw it because the patient had too much drop in blood pressure. So we do not have really good instruments for more optimization. What I didn't tell you so far, the patient had right heart catheterization at the same time of the left heart, of course. And as you can see here, the pulmonary pressure is in the upper limit with about 40 millimeters of mercury. Very well agreement with echo, by the way. But the mean value was about 25. So by definition, it's not a real strong pulmonary hypertension. But what is surprising, and I think this is why I show this to you, he had a very high unexpected V wave. So I thought, oh, maybe the mitral insufficiency is underestimated, and as shown by this high V wave. But there are many more other reasons, or some other reasons, for a high V wave in the pulmonary capillary pressure. this must not be a discrepancy of the mitral insufficiency. There's another explanation, and it's very well described here in this paper just published last year. It says tall V waves were observed in the wedge position in the absence of mitral regurgitation, and this is called the stiff left atrium syndrome. And this has nothing to do with ablation. We know the stiff left atrium syndrome from people after having had ablation for ventricular fibrillation in the left atrium. But the first reports, I didn't know this, the first reports on stiff left atrium were published even before the ablation period. So what is the concept of therapy of this syndrome? The concept is to make a hole in the atrial septum. It's called atrial septostomy. And after atrial septostomy, one of the devices is shown to the left. Actually, the pressure-volume relationship before on the left side is not as steep anymore as on the right side. Of course, you do not make the left atrium smoother, but the blood escapes to the left atrium and the blood pressure increase in the pulmonary is not as high. So this is my last slide. What are the plans for the future? I think we have to treat his PVCs. This might be a part of his mitral insufficiency problem, but I will not try to reopen the occluded marginal because it's dead. And as we said at the beginning, our job in frailty patients is not to harm the patient. And why should I put him on the risk for a very old chronic CTO if the myocardium is already dead? That really doesn't help him. But I think we should try to reopen the occluded right coronary. There is viable myocardium. And then, of course, we have to look if there is improvement of symptoms. And if not, then I would do something which we usually don't do, which is a physical exercise test with continuous wedge pressure, or even better, with continuous left atrium pressure registration. And if the disease SLAS, stiff left atrium syndrome, is confirmed, we should consider to make a hole in the septum, and then we hope this will improve his quality of life. And I think this this procedure could be justified even in this 88-year-old frailty patient if this diagnosis is confirmed. Well, this is our goal. Make it good life till you're 100 years old or even more. Thank you.
Thank you very much, Dr. Silber. We've probably got time for just one or two questions. It's nearly time up. But it's quite interesting for an elderly patient with impaired renal function. In the end, you've been quite invasive. Do you think that opening the right coronary, if it's possible, might actually improve the mitral regurgitation? Because there may be papillary muscle ischemia, of course.
Well, the answer is I don't know.
No.
I hope, but it looks feasible. At least there was a stump behind the occlusion, and it's a dominant right, and maybe the occlusion of the right and of the marginal change the way of contraction of the left ventricle. So sometimes if you change the way of contraction, the papillary muscle and the mitral valve behaves differently. But and maybe even there are less PVCs with the opening of the right. At least I think it is justifiable.
Okay, time for one question, please.
Very, very fine case, but generally speaking, would you like to include a geriatric evaluation for this kind of patient? Would you like to treat in a different way this kind of patient with high comorbidities and frailty probably, that are more, where it is more important to control symptoms than to prolong life or to prolong
well, I agree. Yeah.
And the last, the secondary prevention is the same as in normal people. These are essential questions for, generally speaking, for the population of frail patients.
Well, in this case, 88-year-old, of course, it's all about improving quality of life and not improving prognosis. And he said that he does not want to live like this anymore, and he's 88 years old, but he's very bright in his brain, and he said that his brain does not fit to his body, so he wants to get his body better. And if this diagnosis is confirmed, I think we could help him. The other question was about secondary prevention in the elderly. I'm not a specialist, I'm not a geriatric physician, but in general I think if we talk about coronary disease, the guidelines should be extended to elderly people too. And he's 88 years old and he had an LDL of 63. I think it's very good, and why should we go for higher LDL values in elderly? I wouldn't do that.
Okay, just very quick last question, please, and a quick answer.
Just want to make a short comment. I think we should learn from those cases, which we have a lot of every day, that chronological age is not the biological age, and therefore I highly recommend the assessment tools which we have, and which are for minutes done, or in minutes done, and we should do the geriatric assessment before we do discuss those cases.
You said you want to do a geriatric this diagnosis before you go on with these things, yeah? Yeah, but this will not probably help his problem of shortness of breath of a walking distance of 20 meters. I mean, you can do that, but there was an old verb maybe to finish this. You are as old as your coronary arteries. Maybe we should switch and say you are as old as your left atrium. I know.
Thank you.
Now, I think the point she was trying to make is that before embarking on lots of investigations and treatment, a more holistic assessment of the comorbidities and what's important for the patient would help you in making the decisions. But hopefully some of that will come out as we move through the session.
Okay, but that's the job of the primary physician, not of the cardiologist, I think.
Okay, thank you very much.